Great. So it's a real pleasure to be here to talk with you a little bit about the Canadian Malnutrition Task Force as an example of knowledge translation for clinicians when thinking about working with private partners. And I've got to say, I'm not an expert by any means in this. This is just the experience that we've gone through, and hopefully that some of you can learn from this experience as well. So what I'm going to try to cover off is what is knowledge translation from the academic's perspective, because we've heard different perspective on what that might look like in terms of talking to consumers at this point in time or talking to other groups, health professionals, for example. But what is knowledge translation from the researcher's perspective? And why is KT, which I'm going to use that term, that short form, relevant to private and public institutions? And also from our traditional forms of communicating how we're moving towards KT. And this is really a road less traveled, and there are not too many scientists doing this yet in the way that I think we need to be starting to do it in terms of actually changing practice and care in Canada with respect to nutrition. Then finally, the CMTF example. And the key lessons I've learned and the group has learned around this in terms of understanding your partner's drivers and needs, both on both sides of the equation, and understanding their strengths, and then how you can build and sustain this collaboration. So this is, again, based on experience, not any theoretical knowledge beyond the KT piece. So what is KT as per CIHR? You've got to think about how this happens. First off, it's dynamic and it's iterative, which means you fall into it often before you even realize you're doing it. And that was our experience with CMTF, certainly. It can be a synthesis of knowledge, so bringing together knowledge pieces that make a statement, like a practice guideline, for example. Dissemination of knowledge, that typically in an academic environment looks like manuscripts, for example, or presentations like this. But it's also the exchange of knowledge, and I think this is really where there is this huge strength in our understanding what KT is by the CIHR definition, this idea that practitioners, consumers have something to say and can exchange that with the academic environment. And we need to exchange back and forth that knowledge to actually make change. Then finally, the ethical sound application of that knowledge as well. And why are we doing this in the first place? And again, this is from the definition. I just pulled it apart into these three components. It's really, we want to improve the health of Canadians, provide more effective health services and products that strengthen our healthcare system. That's why we're doing this and the business that we're in. And as a clinician researcher in an academic environment, that's my reason for being and doing what I do, is trying to improve the healthcare, specifically in my area of older adults. So this is the knowledge to action process, which you may have seen already from CIHR. And I'm not going to go through it in detail for you here, but just a few key things I want to point out. One being this center part here. When I'm going to show you a similar diagram in a few minutes, think back to this diagram. And a lot of the work of CMTF in the first 3 years was here. And now we're moving into this external cycle, what we call the action cycle. So the middle here is knowledge inquiry. Sorry, back up. Knowledge inquiry, and synthesis and tool development, and its outer circle is moving it into action, okay? And so this is a full spectrum of how knowledge translation can be actually seen using this framework, which we found really useful within CMTF. So why do researchers or clinicians need to be involved in KT? We need to benefit the populace for whom we get our funding, whether we're in a hospital or university setting. And so if we're in our ivory towers and doing research that doesn't really have that application as a health researcher, it's a little bit of a challenge. And for me, certainly, it's not something I want to be doing. I want to see actually research that changes what we do in terms of caring for patients. And back when I was a clinician doing research in that local setting, I realized the power of research. I had worked as 3 days a week as a clinical dietitian at a chronic care hospital, and I had 2 days a week to do research that was funded through the Ivy Foundation at Western. And I realized how evidence could change what we did just in that little local environment. I thought, boy, I really need to move on and think about how we can actually change practice across Canada and think about nutrition care of older adults specifically. Funders also consider KT relevant in their funding decisions. This has been going on for a long time at CIHR, and you're seeing more and more of it as we move into different pathways of funding within that institution. But right from a decade ago, you'd see, how are you going to translate this information beyond your little study that you're doing? What are you going to do with it? And now we actually have funding calls specifically for knowledge translation, for synthesis, et cetera. So it's very much driving the funding as well for clinicians and researchers in this environment. We also see funders are increasingly requiring in-kind or financial commitment from stakeholders. And so whether it be CIHR or TVN or other granting agencies, they're seeing a need to bring in stakeholders, which hopefully ensures then that the research is as applicable and there is this true exchange of knowledge that's happening. And it's to help bring that, that research into a broader stakeholder network, hopefully to have that application. So as we're seeing those funders wanting this means clinicians and researchers going for that funding have to be able to pick up the ball and figure out how to involve these stakeholders broadly in what we're calling here today KT. And then if the exchange happens, it truly stimulates further research. CMTF has gotten to the place it's gotten to because of the grassroots, not because of us. And so the grassroots has picked up the issue and fed us what they needed. And from there, we've moved forward in terms of knowledge products. That didn't come out of our brains automatically. And so that true exchange does change what we do as researchers and can change the field as well when it comes to practice. So how do researchers and clinicians commonly get their research out? So conference presentations like here at CNS and other presentations, scientific and journal publications, of course, curricula and lectures, textbooks, publicity on university or hospital web pages, newspaper, magazine articles on research programs of research, presentations to professional practice groups. That's typically what we're comfortable with. We might not be as comfortable with the media piece here, but we often have in hospitals and in our universities people that tell us how to interact with the media, and certainly all of us who work in an academic environment probably have had those training sessions on how you speak to the media. And there's lots of interest in doing that. So they want to see universities and hospitals in the visual field of consumers and politicians, so they have a presence in essence. And so this is an important area, of course, as well. But these areas don't reach practice necessarily in the same way that we would hope to. And that's the challenge, right? So why does private business think of when they see or think of the word KT? And I actually passed this by one of our partners, Abbott Laboratories, to see what they thought of my language here, and they confirmed that this is sort of what they think about. And so they don't see it as knowledge translation, they see it as marketing. And so it's a double-edged sword, I guess, or one end of the spectrum if you want to think about it that way, but they're really a similar thing when you think about it. They're trying to take a problem and get people to understand that problem and move forward. And so specifically, what is the problem? So in the case of CMTF, it's raising the awareness of malnutrition and how the problem can be solved. How can we improve patient care? What is the product? Why the product should be used? Evidence behind the product's effectiveness. Value of the product in addressing the problem. And of course, selling the product. They have a profit margin that they have to retain. We all have to understand that. And so there's, this could be a value, a service, or behavior. Those are the products that are being sold by various companies and private enterprise. So marketing is more aligned in the view of the private partner of this thing we're calling KT. So here we have a scientific product that is being produced by the researchers. We've got publicity often at the university level or the hospital level, and we've got companies that do marketing. Somewhere in the middle is this thing that we can do, this private partner, public partnership around KT. And so we're going to talk, as I said, about the example of CMTF. So if we think about the scientific product, there's been 3 studies that are either in process or have been completed. So first was the National NCCH study, which is the national study that we did looking at hospital practices, and that ended in 2013. The Impact study, which was funded by TVN last year, actually took that knowledge and rolled it into a tool or a product. And then the Morteep project, which was just recently funded for the next 2 years to do the implementation phase of the Impact. When we think about marketing, we've got industry partners. So within CMTF, we've had right from the beginning, and we still do have industry partners and proudly bear that acknowledgement. And for publicity, we think about nonprofit partners. So CNS and DC specifically, nonprofit partners that help us with publicity around this issue. So let's talk about the example briefly. So I'm using the example of our visionary sponsor, Abbott Laboratories, because they were there right from the very beginning and really were the big instigator in why CMTF developed and evolved. And when I asked Anne Dumas and her boss, Richard Bond, to give me an understanding of what they saw this thing was that we created over the last 5 years, they had this note in their brief to me. And I thought, this is a perfect quote. This is what it's all about. It's a good public-private partnership represents a relationship in which both parties work together towards shared objectives in a collaborative manner. And so highlight good there, because there's lots of PPP, I think, that isn't necessarily the win-win that we want to see it to be. And it really takes this relationship building to make it happen, working towards a shared objective. So that's what I'm going to talk about now. So if you remember at the very beginning, I showed you the KTA cycle that has been developed and is disseminated by CIHR. Here I've mapped on the CMTF process. I don't expect you to read that. We actually have a poster at the session, not sure what day, if it was Friday or Saturday, that Celia Lohr, my current PhD student, has put together this poster talking about this. But what I want to highlight for you is that right from the beginning, we were doing this work, not even realizing we were actually creating knowledge and moving into tool development until we started to look at these frameworks when we thought about how do we implement this and thought, this is an amazing fit. We've been doing this all along. So back to my very first point, that often you fall into KT before you even know you're doing it. And you have to be realizing it's a very iterative process, which is what you'll see with this program of research. So we'll go through it in detail here, but you can check out the poster that we have later in the sessions over the next 2 days. So Story of CMTF. So Abbott Laboratories actually brought a group of opinion leaders together in February 2009 to talk about the issue of nutrition in Canada. And about that time in Europe, there'd been something called Nutrition Day being taken up by many countries, different hospitals, to look at the issue of malnutrition in acute care. And we, as a group, said, we don't really want to do that. We want to do something a little bit different. And fortunately, that idea took hold and grew. So CMTF became a standing committee within the CNS in 2010, and we developed a proposal for the Nutrition Care and Community Canadian Hospital Study. We collected data then, which is this knowledge inquiry phase of the K2E over the next 3 years. And all the operations were funding from Abbott Laboratories as well as other industry partners for the entire data collection. And they saw the value in collecting this national data for their own concerns around raising the issue of malnutrition awareness in acute care hospitals. And so that's where the value is seen on the private side. We then got into website development and a KT vehicle, and this is basically the idea of knowledge synthesis, so bringing together knowledge for partners across Canada and those folks who are interested in hearing more about the message. This was from in-kind and additional funding from Abbott Laboratories as well as other key knowledge translation pieces. And again, they saw the value of this KT being done by an arm's length group away from the industry. So it's, again, growing that trust and that relationship. We then were doing quite a few grand rounds on preliminary and final results. And this is where the grassroots really started to take hold and led us to the path we're on now. And as I said at the beginning, the grassroots exchange of ideas really moved CMTF forward. Without that, we probably wouldn't be where we are today. But really, and it was Kush Dujiboy who said this in a meeting, we have made a lion that has to be fed. And so we created this appetite for trying to solve malnutrition in acute care. And as researchers, we couldn't just drop it, right? It didn't make a lot of sense to drop it. We were the best people to keep the message going forward. So we had to learn new skills and learn new ways of working and thinking about how we actually feed this lion. And so we identified, they identified for us their knowledge needs. And so a lot of our work over the last 3 years, 2.5 years, has been what are the needs of the grassroots that we can actually try to fulfill as a group within CMTF. And then as of 2014, we refocused our structure to be more around this idea of KT. We're no longer in the business of doing the actual research, which was our mandate for the first 3 years of when we started. We're really focused in on KT and supporting an investigator-driven research process rather than CMTF driving the research. And so just to add to that is we do have these 2 further studies which are investigator-driven KT research, and they truly are KT research. So they've taken these knowledge that we've developed and packaged it in a way that can be used by others beyond a manuscript. And so in 2014, we were fortunate to receive a CALIS grant from Technology Evaluation for the Elderly Network to synthesize and develop tools which could actually roll this knowledge out into the community. So just to give you an example of this, one of the key things we found in the NCCH study was there's a lot of barriers to food intake. For example, 30% of people can't open the packages of the food that they get on their tray, or their tray is across the room. Those are barriers to food intake. But no one was watching these barriers because there was no tool to track it. So as part of this CALIS grant, we actually created a mealtime audit tool that's now been tested for inter-rater reliability and demonstrated its validity and usefulness in the acute care setting. And so we've created a tool that can be used by food service departments, dietitians, others, to actually track barriers to food intake in acute care. All right, and so we also created the integrated nutrition pathway for acute care. I'm not going to show you that today, but again, if you're interested, we have a talk tomorrow talking about interprofessional care, and I'll be highlighting that end product in terms of a tool. So we created these tools, and so we had this wonderful idea, well, they're there. The grassroots was still telling us, you're not done yet, because we need to know what are the resource implications of putting this into place. How do we put this into place? How do we change practice? So again, it wasn't CMTF having this grand vision of where we were going, listening to the grassroots saying, really, you need to show us how to do this, what's going to cost, what are the resource implications of this. And so that's where the next study came out, which was the Strategic Impact Grant we just received. And it's about testing this impact in 5 hospitals in Canada. So at the stage of just in the developmental phase with data collection happening starting in the fall. So we're very busy right now. But that moves us into this full action cycle of KTA. Again, back when we started this in 2010, we had no idea this is where it would go. And so it is a very much iterative process that you have to be open to, that you're not going to have a plan of a program, a study, and know where you're going. As a researcher, you have to be able to be open to different agendas and moving forward in terms of research. The key thing as well is that both of these projects have benefited from the private-public partnership specific to KT, because the TVN required 25% of the budget to come from in-kind or other resources to get funding, which meant we had to have stakeholder partners who were willing to put money or in-kind to support the project, which meant we had to have stakeholders in the private business as well. So what are some CMTF key activities? So some things we do around push. I won't go through these too much detail because of time, but things like our website where we're pushing out resources, e-newsletters, presentations to various groups, and we're doing a PR campaign this fall, linking it up with the Malnutrition Week. So those are all push activities. But in terms of pulling, so that exchange of knowledge translation from the field, from consumers, we're doing these sorts of things. So sharing your story on our website, discussion at grand rounds, which leads us into new ideas about what resources people need, what briefing notes they need, what sort of slide decks they need to train their physicians or pharmacists or whomever it may be about this issue. So we respond to that rather than always directing it. Industry reps with their ear to the ground. And so I had the pleasure of speaking to some Abbott reps recently and other reps, and they have their ear to the ground. They're in the field with clinicians talking about this issue, and they hear back. And then that can come back to us as CMTF, and we can say, hey, this needs to be maybe put into a new product in some way, shape, or form. For example, the idea around resource utilization and the whole issue about how we monitor that and track that, that's being built into how we actually collect the data in this More to Eat project. And then finally, stakeholder meetings and webinars. We've been conducting those right from the beginning as a pull activity, not as a push, to find out what stakeholders needed to change practice, to change what may be happening around the nutrition care landscape. Some of our key products, we repurpose things. So back to knowledge translation. How does this work? Well, some of our original research pieces are actually useful beyond research. So we have a patient access and satisfaction questionnaire. If you go to any hospital in Canada, they typically have, is it Picker? Is that the name of it? NRC Picker is a way that they assess quality and satisfaction with the patient. And so patients will randomly be sent email typically, or sometimes a mail, a questionnaire. There's one question on nutrition. And so when 45% of people going to medical surgical units have malnutrition and there's huge barriers to food intake, all these sorts of things, they're not being picked up in these questionnaires. And so the question that we use, which is valid and reliable from the UK, we have basically put on our website with of course, permission from the UK authors. And they said, yes, please have it there. So other hospitals can use it as a patient satisfaction questionnaire rather than this other system which may not get at the detail. Physician and nurse surveys as well that we created I shouldn't say we created, we modified from a group in Denmark. Again, asked for permission from the Denmark researchers to say, can we put this physician nurse survey on a website for others to use? And they said, please, definitely do that. And so these research tools became now knowledge translation. So they're not just a way of actually developing knowledge for the research enterprise. We've also digested evidence, and so we've certainly got publications out there. I believe we have 10 publications now from the CMTF and about 4 or 5 more in the works. But rather than giving a manuscript to someone, which they can't necessarily digest, we actually make précis of all these articles. And we have reviews on our website. So one of the key things we developed was a nutrition screening tool that we think is simpler and more real life in terms of being used in acute care. And on our webpage is a comparison of all the acute care tools that are out there in the literature and why they may choose the CNS tool rather than these other tools. So all of that digestion of evidence away from the manuscripts into a more readily available piece of information. And we had little pieces written like, for example, Chris Gigi Boy wrote a one-pager on why you don't want to leave a patient on NPO for 3 days. What happens to their body when you do that in lay terms so that the patient, the family, and professionals who are not nutrition professionals can understand why this is such a detrimental piece. We've also been in the practice of creating KT products specifically as research, and this is because of the TVN grants specifically. And so these are things like the CNS tool, but also the INPACT, this integrated nutrition care pathway, the mealtime audit tool, and the meal intake tool. And then finally, we reframe some current clinical tools. So the SGA we used in our NCCH study, we recognized that one of the challenges with getting people to use this beyond research is to make it very accessible and understandable. And so we're trying to repackage that work and add to the work that Kush did around developing a video to make it actually even more relevant to practitioners so they can pick up this skill. So one of the key things we had in terms of learning, so now moving past example into learnings, and again, these are my reflections on what I think we've learned in terms of understanding partners. This is the first foray that I had in a significant way working with private practice. So I had to realize and learn that business opportunities the business gets into KT or will get into this sort of partnership if there is an opportunity to grow the brand. So you have to figure out who are the companies that have potential profit to be made from growing their brand because of the issue or problem that you're looking at. You have to be time sensitive. Businesses move fast compared to academia, right? Academia moves very, very slowly. And so there's a yearly cycle of budgets that you have to be ready for, and you have to have ideas for, and be able to move for that. And we didn't know that. We thought CIHR timelines, right, or ethics timeline at universities. We didn't think, okay, July, you got to have a sense of what you want to do because October they do their budget and it's approved. We didn't have that sense until we worked with our partners for a while. Client loyalty and improved relationships is key to your industry partners, right? They want to build that client loyalty, that relationship with their consumer. And so if your work as a researcher can bring that loyalty about, that's a good thing. They always need fresh material when thinking about marketing, right? So they need an entree to an audience. And so, for example, with CMTF, having available our article précis, for example, readily available on our website, our industry partners can pick those up and take them out into the field to their clients and say, this is what's going on around malnutrition research. Have you heard of this? And what are you thinking about this? And so that having that fresh material always available helps them have their foot in the door with an audience. Key opinion leaders, development of those, and to support present and future business initiatives. And so our industry partners realize the credibility and value of having these key opinion leaders aligned or a group of people that they can go to. And so they recognize developing relationships with researchers and clinicians who are credible is very important to their business. And then finally, the access to the experts. And so being able to pose questions to CMTF, or thinking, for example, reviewing promotional materials. Many of the CMTF members have reviewed materials coming out from industry partners to say, this is really what is the focus of the work of CMTF and what you should be highlighting here. In terms of understanding the research and clinician needs, it's publish or perish, right? And so private partners have to understand that's our bread and butter. And so if we can't publish the research, there's no point in doing it. And so this can be a frustration, of course, for the private partners who want to see things moving quickly and getting out into market, et cetera. But we need to publish that, and we need to publish it in a way that is appropriate and credible, and also in terms of timelines, thinking about we don't want to release news without actually having it peer-reviewed. And so dynamic for the academic is really important. And scientific freedom is our credibility. And so private partners need to understand you need to be arm's length. There can't be this oversight in terms of attempting to determine what we study. So the arm's length relationship means the researcher has to determine what is to be studied. They have to be at the charge of the knowledge that's being created and the message that's being created around that, right? And not the message being created by others. Funding to support research in KT is needed, and so this is what industry may not always understand that we do need funding, whether it be for the research enterprise itself or the products of that. And we are experts in knowledge creation, but not in the packaging. I think every academic here will say that, I have no idea how to do that. And how do you go from there to there? And it's wonderful to hear about CFI and other groups like that that are working with the researcher scientists that has the credibility from the public and being able to take that and package it and move it out. Because back when we were doing this 6 years ago, there weren't those services necessarily available. We've had to learn how to package things, but we don't necessarily have that expertise. And it's a very slow process for research and publication. Understanding our private partner strengths, numbers. So they have this. Most industries will have a significant number of people who can be disseminators for you, right? You don't have to be the disseminator. And so you can capitalize on that. They have access points that academics do not have. So they get right into the hospital in the case of CMTF that I don't have access to. They meet with the dietitians or the physicians that I do not have access to because they're not reading the journal that's on the dusty shelf in the library, right? And so they have a different access point and a way of getting at some of these individuals that we're, as researchers, interested in getting to. They have skills in sales and marketing, which I will never have. So just to give you an example, posters that we created originally for one of our early conferences, we did in PowerPoint, and they didn't look anywhere near as good as when we asked one of our partners, Abbott specifically, can you take this content we've got and make it look really nice? And what came out was truly amazing. We had this bank of beautiful posters at ESPN in 2011 that caught the eye of everybody because they were so unique, because they came from a group that knew how to put together an eye-catching piece of material for an audience. They know how to package a knowledge product. Okay, I've learned more about clear language in the last 6 years than I ever had before that, in the 20 years before that. And so they know how to say things in a way that grabs attention, which we don't as academics typically have. They have business contacts with key skills like marketing and PR that no academic will ever have that sufficient skill. That's not what we're good at, right? And so this is why the partnership is necessary. And then finally, they also have a network of decision makers that's often beyond who typically an academic would have in their circle. In terms of the strengths of the researcher and the clinician, we know our content area best, right? And so we have that knowledge. We have it at our fingertips that industry doesn't have. And we know how to understand that literature as well. Often it's variable quality. We have expertise in conducting research. So again, this is where it's a valuable relationship, both the lab that we might have specifically or personnel with specific skills. We have the credibility that our private partners would like to capitalize on. Again, think back to Roxy's presentation. Who's trusted is the scientific researcher and the moms of the scientific researchers. So we have that credibility, but we don't have the skills around packaging it, right? We're used to packaging it as a manuscript or as a presentation like this, which other people would not listen to, right? And we have a network of researchers and clinicians with similar interests. Again, this is where we benefit our industry partners. And so I do a lot of geriatrics outside of CMTF, and we have something called Agri-Food for Healthy Aging. It's an organization that brings together researchers like Alison Duncan over there, and myself and a few other researchers in the Guelph and Waterloo area. But that access, we've had companies come to Agri-Food for Healthy Aging and say, hey, what are you doing over here? Because they see that we have this access to researchers and clinicians and other groups that have interests similar to ours. So how do we build and sustain this private-public partnership? Again, this is just our experience. It's not necessarily the way forward for everybody, but some key things that we've learned. You need to find partners with a similar agenda. And in the case of CMTF, we had to find a partner that was interested in preventing hospital malnutrition and improving the clinical outcomes for patients. That was key. Relationship has to be mutually beneficial and considered long-term by both partners. This is not a one-off experience. The strength of CMTF, it's been 6 years in the making. We have to trust, and this takes constant work, right from the beginning through every interaction you have, both on the researcher side and the private partner side. You have to identify and minimize your conflict of interest at all times. It's a constant thing that you're doing, and transparency. I think we're getting pretty good at this after 6 years, but I can tell you in the beginning it was like, oh no, I'm not sure what's going on here, and it's all about this transparency. And we found within our industry partners having a professional, in this case a dietitian, that was a liaison was key, because marketing folks talk very differently than health professional folks do, and they have a very different agenda. So if you have an industry partner that has a health professional view, if that's where you're in, or a scientist within that private enterprise that is more in line with your understanding and background, that's a better fit for being the key link to you as the researcher, right? Create and clearly define and have your goals be very achievable. And this is a constant renegotiation. You have to understand your partner's needs and strengths. So we've had to educate our partners to say, hey, the paper's not out, which means no data goes out until the paper goes out. That's just the way it is. And it's become an area of people understanding this is the way we operate. We don't do things otherwise. Communicate, communicate, communicate. I have learned probably the most important thing about knowledge translation is communication and clear communication among all sorts of partners, but specifically with our private partners as well. And the key is figuring out who and how. That's often the hard part for a researcher. We don't know how to get through the structure of a private business. You need frequent updates in person and by other means, and again, transparency in those communications, being very upfront. This is the way it is, and if you don't like it, that's unfortunate. And then finally, being flexible and adaptable. As a researcher, this is often a challenge for us. We're often used to driving the process, and we have to realize we can't always drive where the knowledge translation is going to go, and certainly in the process it may take sometimes. So in sum, the CMTF private-public partnership is still being written. It's not finished. And I'm sure we will learn more over the next 5 or 10 years as we go forward with this initiative. But what I have learned personally is that private-public partnerships, for KT specifically, it's extremely worthwhile. So as a researcher in the room where you see KT as being something you need to be getting into, you have to think private-public partnerships. It takes time. This is not a one-off, and so you have to build a long-term relationship, which can be a challenge. It takes a huge amount of time. If I can count the number of hours CMTF has taken over the last 6 years, it's huge. It takes work, and you have to develop new skills. As I said at the outset, I've become a much clearer communicator since I've taken on this project and learned from my colleagues in private business. And you have to learn new skills, even within your research area. For example, one of our knowledge translation studies, the impact study, we had to do a Delphi study. I've never done a Delphi study. I had to learn how to do a Delphi study. So you have to learn and adapt to these new skills that meet the criteria around credible knowledge translation research, but at the same time get you where you want to be in terms of changing your practice and healthcare knowledge for your practitioners. And then finally, it's necessary. If we're truly going to change things, and specifically around malnutrition and acute care hospitals, this is what we have to be doing. We know that malnutrition has been happening for 40, 50 years in North America in our hospital settings, and it hasn't changed. You look worldwide, if studies have done similar sorts of work in Europe, it's a very similar prevalence. So we need to make some changes with the way we practice to actually change this in some way. And so we really think we're going to impact health outcomes of our population, which funds us as researchers and clinicians. We have to be involved in KT. So just some acknowledgements here: CMTF, CMTF 2015 funders, research funding for myself personally, UW research team specifically on the CMTF, our KT partners, of course, and then any discussion. I guess hearing the survey that was out there, a lot of researchers said, we don't know how to do this, KT. Other researchers in the room, have you started to do KT? And is any of this ringing a bell at all with you? David, can you comment?
Yeah, so this morning I just jokingly said that maybe I shouldn't be the one up at the microphone, but I think there's a new reality emerging, and I think we just need to be more aware of how our environment is changing, and to continue to update our skills, so that we remain relevant. So I think all the points you raised were very, very, very cogent.
I think, Heather, you've illustrated a few things. The academic has to be market, or work. Yeah. Mark, you are very nimble with respect to how you've moved through this field. And my perception, I'm not a key researcher, but that in research you're good at sticking to an aligned methodology and not veering from the rules and following a certain path. So implementation science is messy. It's really messy. It's not pretty. Yeah. And so just back to the issue of flexible and adaptable. I mean, we didn't call what we were doing 20 years ago implementation science, right? It was applied science or participatory action research, right? And so now we've got this thing called implementation science that we're trying to do, which really fits with KT really well, but it's constant renewal of skills. I was trained as an epidemiologist, and so I do a lot of qualitative work. Now you kind of wonder, what is she doing? Right? Now I'm doing things that are moving beyond that. And so you have to be, as a researcher, looking, if this is the agenda you're on and you have a place that you're trying to influence, KT and implementation science is going to be one of those things you're doing. Yeah.